Just to start with, I don't know how much you know about the Wiltshire Clinical Commissioning group, but I'll assume that you don't know much about it at all. We've been in operation only since the 1st of April this year, so just about 8 months. People think that we've taken over from the Primary Care Trust. We have taken over some of those responsibilities, but it isn't exactly the same. The focus very much that's different is that this is clinically GP-led. And John, for example, is a good example where he's a member of our executive board on the locality group. It's really important also for us, besides having clinically led, we very much want to be subsumed within the local population. So as Group Director for New, I'm very keen to engage with you, the other area boards for the North and East Wiltshire, to understand what you want about services for yourselves and your family and neighbours. So it's important that we get that feedback from you. We'll maybe talk in question time about how we can continue that dialogue. It's very important to us to ensure that we have good quality services, and again we'll look to our clinical GP leads like John to help us and guide us in terms of how we commission services for the future. The focus is very much on kind of acute and community services for our population of Wiltshire, of which my focus and John's focus is on the North and East Wiltshire side. So just a very brief slide about what we're about. We have a governing body that is made up of 3 locality areas in the main. That's New, as in North and East Wiltshire, West Wiltshire, which include Jatton, Kennel and Devizes, and Sarah, which of course covers all the Salisbury area. Each of those locality groups has a chair and vice chair that are GPs in the community. And we have a chair overall for the governing body who also is a GP. As you can see there's a number of other lay representatives as well to take account of the public's views. It's very much, as I said, led by our GPs in our local area, and I think that's what the very focus is and what's different about how we commission services on behalf of the population of Wiltshire differently than it's ever been done before, in my view. I've been in the health service 31 years now. Our vision is built around providing care closer to home. Where we can do so appropriately, we'll deliver care in people's homes. But where it's appropriate to deliver them closer to home, such as primary care centre up the road, possibly within care homes, in terms of providing additional healthcare support, or in community centres, then we will do so. We obviously are working closely with our hospitals, both the Great Western Hospital and where you refer to also in the Royal United Hospital, about how they deliver services effectively for when we need to go in and utilise those services appropriately, for more specialist treatment, then we should do so. But our focus is trying to deliver care within the community. We've got 7 priorities for the CCG. These have been built again by what the public has said to us and what the GPs have said to us locally. Bearing in mind that we are a membership organisation of all 57 practices across Wiltshire. So we're very keen to ensure that we take account of all practices, as well as, I think it's a 6 or 7 GPs on our executive. 7, of which John is one. We recognise that we want to keep people as healthy as possible, and the large majority of the population in Wiltshire are healthy. We have a growing ageing elderly population, of course, which puts additional pressures on healthcare. But we're keen to ensure that people can manage their own health as best as possible, and give them, working with our public health colleagues, to ensure that we do provide good advice out there around lifestyles and behaviour, for example. But also to ensure that, where people have a long-term condition, that we're providing advice out there as well. And that might be with the GPs, or through advice, through signposting advice and information, particularly again working with our council colleagues, but also the voluntary sector as well. We've recognised that mental health has been a key issue for us in Wiltshire. And I'll talk to you in a moment about what we've done so far in our 8 months of life as a CCG. But we're very keen to ensure that there's good services for mental health for the people that we serve. A particular challenge for us is regarding how we manage end of life and long-term conditions because of the ageing population. What we have now is people living into their 90s and 100s. I was in a care home the other day in Wiltshire. There was an elderly lady there of 102, and she had all her faculties and all her marbles, but she was still had a number of long-term conditions which the GP were managing really well, again out in the community, and that's what we want to provide really effectively. So turning to what we've been doing for you in the north and the east. Some of this is going across Wiltshire, but others is the services that you can achieve directly. This is not an exhaustive list, but just hopefully gives you a flavour of the sort of things we've been doing. And Chairman, I haven't mentioned 111 because I'm conscious that the performance hasn't been good in the past, but we have tried to, and we obviously inherited this service, but we'd like to think that we've got it in a much better place than it has been previously. However, I'm sure you'll tell me that's not the case in your experience. And I want to know as well. In terms of mental health, we inherited on the 1st of April an 11-month wait for individuals who needed to have either assessment or diagnosis of dementia for those generally of older age group. What we put into place now, and it's available in the Malmesbury Primary Care Centre, is that there's GPs there that provide that assessment directly in primary care. That's mirrored elsewhere, but we've now moved that waiting list that was 11 months on the 1st of April to 4 weeks by the 1st of September this year. Now it's a sea change in what was being available to people to the local population previously. And I think that is also helpfully supplemented by working closely with the voluntary sector, particularly two organisations, Alzheimer's Support and Alzheimer's Society, who, as I've said on the slide, provide additional support workers, again in primary care, in GP practices. So that supplements what the GPs will then offer in terms of assessment, diagnosis and drug management. Turning to the adult population for mental health, we've provided some additional investment across GP practices for mental health liaison workers. These are primarily nurses, I believe, who provide that specific support for individuals who need it when the GP has limited time to spend a large amount of time with individual patients. And again, that helps the GP in terms of managing the workload and seeing others who are unwell. Turning to urgent care, as you probably are aware, over the summer, Great Western Hospital was struggling to manage their urgent care take, and we had a number of ambulances waiting outside. I'm sure Ambulance Trust will advise us, waiting outside the A&E, trying to get access for patients. We've recognised that as a CCG, and we've put additional funding in, provide additional A&E consultants in both RUH and GWH. I'm pleased to say now that they've just got over 8 A&E consultants. When I think when we came in, well, about a year ago, they were told they only had 5. So it's a considerable investment in terms of providing specialist consultant support for A&Es for those who need emergency help. Turning in terms, I suppose, to the winter as well, we've also put in some additional support in for discharge. We're very keen when people access A&E and acute services in hospitals, that we bring them out effectively as well, and we do plan their discharge. And again, we're working closly with Wiltshire Council to join up both the healthcare needs of individuals with their social care needs. Well, it's pleasing to note that the Great Western Hospital have also opened up their surgical assessment unit, so they stream those patients who require surgical intervention as opposed to those that need medical intervention when they were both previously coming together. So, you know, there's greater thinking in there in terms of how we manage people through the acute hospital system, and hopefully you'll see a better system in place. Just finally, turning to community services, We're describing this, I suppose, as our flagship initiative, because we really want to, and the GPs particularly want to, change the way the community services are delivered for us in Wiltshire. And they want to do a stream of different things, but clearly we want to phase those, because we can't do everything with immediate effect, because we have commissioning and procurement responsibilities to follow. But one thing we have put into place is care coordinators in GP practices, assigned to the GP practice. They are actually employed by GWH Community Services, so we want to make sure we have the link. It's almost like they're seconded into the practice, working really closely with the GPs and their practice staff in terms of trying to manage people in the community, trying to provide alternatives to referral into the hospital, and free up some of the GP's time, the other practice nurse time, and other practice staff, to get on with other work. So they're trying to avoid or delay admissions into hospital where it's appropriate to do so, but also trying to drag people out through discharge arrangements appropriately and working closely with the council. One beauty of this, and I see Helen in the audience, and we've talked a few times about this, is that the voluntary sector have a key role to play here. It's really effective that the Wiltshire Council have put a considerable amount of investment into the voluntary sector, and we can work with the voluntary sector to ask them to look at how they can offer help. And I noticed on the table that I was given about a befriending scheme. So many people in our community have a health problem. Often that health problem is linked to loneliness and social isolation. If there's a befriending scheme available in the local community, that can make a tremendous difference to people's health, even if they're living with lots of long-term conditions. And I want to actively promote that, and if you've got some other ideas about how you can deliver other things in the community, or for smaller communities, our care coordinator in Malmesbury, I'm sure, would want to talk to you and see how we can help people. That's all I wanted to say. I just want to give Dr. Pettit an opportunity to talk about Malmesbury.
Thank you, Ted. I've got a cold, so excuse me. I don't know where I got that from. I think I want to start by saying to thank Ted and our CCG management team, many of whom have come from outside Wiltshire and had to really hit the ground running just this summer, pick up a huge body of work with very little local knowledge. I think they've done a really good job in getting things moving. And they are there obviously to support us. I won't talk too much about specific issues, I think they might come with questions in a minute, but I just thought I'd give you an idea of how our work as GPs fits into the scheme of things. Essentially, we volunteered ourselves to represent our own patch on the board, and to offer the clinical input that's required to help things to move forward. We're still very much working job in GPs, 90% of our time. This doesn't take me out of practice any more than half a day a fortnight. What that means is that with that limited time available to the CCGs, we have to be really focused in our efforts and focus in our thinking. Our meetings have to be very well planned and organised, and we have to be very smart at picking up on the biggest current issues, and the management has to be very smart at working out where they need our help. There's an awful lot going on, a lot of which we're not directly involved with, but when a clinical viewpoint is needed, a viewpoint that reflects what our patients are thinking, then we're there to offer that. So we try to represent our patients, we try to represent our GP colleagues, and give that sort of base knowledge that we have from our day-to-day working, feed that into the decision-making system. Sadly, with the old PCTs, and even the PCG, which was the precursor that some of you might remember that I was involved with years ago, there's too little of that. Certainly the PCT, we were excluded from the process for 2 or 3 years and very bitter about it. So it's an exciting prospect, the new setup, for us to have a say, for patients to have a say, and for things to be more clinically led rather than just being driven down from the top. Personally, I think the biggest, if you're going to ask me what the biggest issue at the moment is for the health service, I think it's the care of the complex frail elderly. Largely because of their sheer numbers, and because the system wasn't built, wasn't designed to deal with 85, 90-year-old folks with 9 diseases. It was designed for somebody with a hernia to go and have his hernia done, or somebody with a heart attack sorted, and then come out home again. So we're looking at a phase now in the NHS, I think, where hospitals particularly are having to look again at how they run their services right from almost a blank sheet of paper in order to allow for patients arriving on the wards. Yes, they've had a heart attack, but they're diabetic, they've got big social issues, etc., etc., etc. Hospitals like to pigeonhole people, and you have that problem, you go on that ward and then you go home. That's not working because 78% of the patients are elderly and frail and complex. So I think we're putting an awful lot of effort at the moment, certainly over the summer, into the care of that group of patients, and that's reflected in our dementia work, it's reflected in the care coordinator work that Ted's talked about, and the revision of our community services as a whole. I think there's a lot to be done. I hope we've made a decent start at it. Certainly the dementia service has been well received in Malmesbury. That was a good example of where GPs could see what the problem was, which was a 12-month wait to see a memory expert, and could see that it was an issue that wasn't that complex, that it with a bit of training and backup from specialised nurses that we could provide it in primary care close to patients' homes. And that's what we managed to set up. So I think that's a good example of the things we're doing moving forwards. Single point of access, yes, we're just about to pilot a new point of entry into the system for patients.
Started Monday.
Yeah. As you all know, the NHS is an incredibly complex beast, particularly when it comes to emergency situations. Patients really have no idea what options are available, and there are too many options, too many phone numbers, too many issues. As I was saying to John earlier, most patients who hit the system with an emergency problem haven't dealt with the NHS with a problem like that maybe for years, and they've got no idea how things are running currently. And we're trying to solve that. 111 was an attempt to solve that, a well-meant attempt, theoretically great, but underfunded and poorly commissioned, and so far it hasn't worked out too well, although yes, things are improving. This is a way, not so much for patients, initially it's for professionals, so GPs, nurses, who have patients that have immediate needs, to phone one number and have a team of people, health and social care based, council based, who can draw upon neighbourhood teams, can draw upon additional social work support to provide packages that suit individual patients best. At the moment, even for us, I've got a dozen phone numbers I could ring, and sometimes I'll phone 8 of them within an hour and I'm bounced off all of them, and time is just wasted. So this is a really exciting opportunity to rationalise things and make sense of that, and have that single point of entry into the system. It's a 6-month pilot over the winter, I believe, which is a testing time obviously to bring it in, but if we can make it work, I think it's quite an exciting potential for the service in the future. Half of my appointments are only made available on the day. So when I arrive in the morning, half of that day's appointments are taken over the previous few weeks. The other half are kept for that day, so that people who know me and want to see me, who are ill on the day, not all of them, but as many as we can fit in, can actually book in on the day. That's up for debate in this next year. It's on our list of minor injuries units. It's a hot potato. We'd like to have a minor injuries unit back in Malmesbury. Another option is to provide a sort of lower level minor injury service from the practice, but that would all have to be commissioned at a sort of higher up level. But we've got it quite high on our priority list to review minor injury services. We have more options than most here, but none of them are particularly close. Obviously we did have one in town and that worked very well.